everyone for coming here today and for attending what is now known as our second annual departmental retreat. Very pleased to have you all here today. We've got a very exciting and jam-packed agenda. And so what we're doing this year is actually going to focus on the precision medicine strategy, which is the strategy put forward by the Cummings School of Medicine. It was actually put forward in 2015, and precision public health was a component of that strategy, recognizing though that there's lots still to be learned about what that means and about how that will actually integrate into the overall strategy. And that puts us in a really good position because there is the opportunity to contribute. And we're really fortunate to have here today Dean Meddings, who's going to tell us about the overall strategy, as well as Matthew James, who has been tasked with writing up the report and recommendations about the precision public health component of that strategy.
So in fact, the decision to do a provincial strategy on this really began in May of this year. And in May of this year, I went up to Edmonton to co-chair a meeting with Richard Fedoruk on whether precision medicine made sense as a provincial strategy. We agreed that it did at the time with a whole group of people. And we decided in May of this year that the Academic Health Network was the obvious group to take this forward. And so what we did in June is we hired a new director of the Academic Health Network. We made a somewhat sneaky request to Chris Eagle to co-chair just a small committee with a small deliverable that would be by January of this year. I don't think Chris has forgiven me for this yet, actually, but he mentioned that at the retreat. And they said, well, it's really good that you're going to bring in 25 people. That makes a lot of sense. But if you really want to make a difference in the world today, you're going to have to do more than that. You're going to have to bring in 3 or 4 truly world-class experts in those areas that you think that you're going to concentrate on, because you're going to have to jumpstart the whole thing. And so we thought really carefully about that. As you guys would all imagine, if you think about people who would be in the top 10 or 20 in their field in the world, most of them have a day job. They're not advertising or looking for things to do. And pulling those people to Calgary would be hard. So we set about trying to think how we could do that. And we were looking for people who sort of had a 10-year run, so someone in their late 40s, early 50s, but had already garnered that sort of prestige. And what we have done is we have set aside 3 to 4 packages to get people. And what we've set aside is $12.5 million over 10 years. And what we've said is we would in fact cover half of that, and we're expecting the other half to be covered through philanthropy.
There's something about differences across groups, precision medicine being very focused on the patient level, but today I think we can think about different levels, populations as well. But it acknowledges differences or variability. There's something about prediction, and there's something about tailoring or targeting or recognizing that perhaps there's differences in what might be done or what might be done through a decision in response to this information. So just a few concepts to think about, I think, for the rest of the sessions. I mean, I see a lot of themes in big data, figuring out the best way to actually use data and make it meaningful information. How do we get information to the people who make decisions, and really doing something meaningful at the moment when it's needed. And I think these are all the unifying features that could be applied.
You came here today to learn what precision public health really means. And I think the reason Brenda asked me to chair this panel is because I'm the one who knows the least about it. So I'm here to be educated along with many of you, but I wish to assure you that we have chosen 3 very knowledgeable panel members, Melanie Rock, Tom Noseworthy, and Fiona Clement.
I will say that I don't think precision medicine or precision health means that everybody can have what they want all the time. So I do think there's this push to have an individualized care plan or individualized care, and that can sometimes, I think, be misinterpreted as everybody gets what they want all the time. And within our social system, obviously that can't happen, or else we wouldn't be able to operate within a budget. So just to put out there what I think it isn't.
Creating paradigms where where we do the work to understand what the determinants are of how a person will do, how a person will respond to treatment, how a person can be diagnosed, how a health system can be intervened upon, how a population can be intervened upon, and then analyze that information, present it to decision makers at the crucial moment when they need to make a decision, and then hopefully streamline your use of resources and improve not only the outcomes of people, but also expenditures, so reduce waste in systems.
I think there'll be a ton to discuss, but we're really trying to get at the 2 or 3 key ideas that you want to bring out for broader discussion with the whole room.
There's a number of other projects here that are just starting up, so we're kind of just starting up one on palliative care, one on CT scans for pulmonary embolisms, and we've been working with Alberta Health on helping them with their drug policy, working with Glenn and Braden Mans and Fiona on that as well. And moving forward, all of my research is very policy oriented. I really enjoy that, like Rebecca said, the interaction with government, helping them make decisions that are better. That's what I'm interested in, is helping make better decisions, and that can work well. It doesn't always work well, and there's lots of things that could improve.
My second big thing that I've learned is that policy and research cannot be disentangled for me, and I'm very lucky to have found a home doing drug policy research, where I'm analyzing the policies and their unintended consequences, where I'm advocating for new and different policies based on harm reduction, and where I get to marry those interests in doing research, but also in working with, alongside, and sometimes arguing against the perspectives of people making policies. The 3 areas I'm specifically working on in drug policy are cannabis prevention and education for youth, in the context of the coming legalization that will be tabled in the spring, thinking about new and exciting ways we can engage youth in the school context, developing resources for parents, and having new open dialogue and conversations about cannabis when it's now going to be a legal substance and not something illicit.
So disability studies really looks at the politics of disability, human rights, and understandings of sort of barriers and the treatment of people with disabilities. And I feel like it's a fairly new discipline still, and sort of in its infancy, it was really criticized for being too strongly embedded in activism. And I feel like there's been this sort of reactionary shift to really sort of esoteric or kind of academic thinking in that, and that we haven't sort of struck a balance. And I feel like that sort of leaves a gap in undergraduate education.
As you're hearing about these different concepts, I want you to think about that in particular, about how you as an individual, as a researcher, as an educator, as a member of the community, how you fit into this precision medicine strategy, precision public health, because we're actually going to identify key concepts and we're going to put them up on some of the white paper at the side. You'll hear more about that. And then we're going to have sticky notes at the table, and you're actually going to identify yourself in some of those concept areas, because we're going to leave here today with a vision for precision public health within this larger strategy that all of you are going to be fitting into.